Good afternoon, esteemed dignitaries, seniors, faculty members, and dear colleagues and juniors. It is a proud privilege to welcome you all to the 11th CPC of this institute by the Department of Psychiatry. Now, without much ado, I request the dignitaries, Dr. Deepak Maheshwari, sir, Principal and Controller, Dr. Puneet Saxena, sir, Convenor of the CPC, Dr. Monica Jain, ma'am, Co-Convener of the CPC, and Dr. Sanjay Jain, sir, Professor and Department of Psychiatry, to adorn the dais. We start this program with the floral welcome. I request Dr. Sanjay Jain, sir, to felicitate our Principal and Controller, sir, Dr. Deepak Maheshwari, sir, with a bouquet. I now request Dr. Lalit Batra, sir, to felicitate Puneet Saxena, sir, with the bouquet. I now request Dr. Gunjan ma'am to felicitate Monica Jain ma'am. Thank you ma'am. I now request the CPC team to felicitate Dr. Sanjay Jain sir for the CPC. I now request the Principal sir and our CPC team to felicitate Dr. I.D. Gupta sir. I request our Principal and Controller sir and the CPC team to felicitate Dr. Shiv Gautam sir, stalwart of Psychiatry. A lot of appeal of internal medicine is Sherlockian, solving the case from clues. We are detectives. We revel in the process of figuring it out all. It is what doctors love most. So is the CPC, a process of case presentation followed by a set of differentials, narrowing it down logically to the final diagnosis. With this, I request Dr. Deepak Maheshwari sir to address the gathering for the CPC.
Dr. Gautam, Head of the Department of Psychiatry, all fellow colleagues, faculty members, I welcome you for the psychiatric CPC, for the CPC by Department of Psychiatry. I think with gradually we are improving the numbers. The attendees are now little more, and I don't want to take much time. Please, I think we can go on with the proceedings.
As the custom goes, I now request Convenor of the CPC, Dr. Puneet Saxena sir, to give the SOP of the program.
It's okay. Good afternoon, everybody. Principal sir, Deepak Maheshwari ji, Dr. Sanjay Jain, HOD Psychiatry, Dr. Monica Jain, who is Additional Principal Academics and Co-Convener. And I welcome all the senior members. I can see a special welcome to Dr. Gautam sir. He has been our teacher and mentor to the college also, so most of the faculties and the students. So welcome you, sir. Again. And I can see whole of the psychiatry department over here, and the senior members, Dr. S.M. Sharma sir is here, and Department of Cardiology, and all. We have seen improvement in attendance, as rightly said by principal sir, that we are improving in numbers, and that should be the right thing, because every department put in so much efforts to prepare the case, and we choose a multidisciplinary case which touches the interest of almost everybody, right from the undergraduate, postgraduate to the faculties. So Dr. Deepak Mathur last time they presented a very interesting case of skin. So same way, I hope that today also psychiatry department will present a case which touches all of us. And we all know that psychiatric problems, they are on rise like anything, and they are basically touching every department. Every department gets patients which require their help. Regarding the protocol, we give first 15 minutes to the department for the presenting their infrastructure and functioning and the future directions which they seek, and followed by the case. And it is most of the time multidisciplinary case. We require pathologist to radiologist, but since this is a psychiatric CPC, so let's see what they have to offer to us. So I hand over to Madhu to please carry on. Thank you very much. So next CPC will be by chest and TB department, and as we all know that it's on third Thursday of every month, but 15th August would be holiday. So sir, we will be doing that on 22nd of August. So if anybody is present from chest and TB department, please make a note of it. Thank you.
Now I request Dr. Sanjay Jain sir, Professor and Head of Department of Psychiatry, to give an intro about his department.
Well, good morning, everybody. Dignitaries on the dais has been vacant though. Senior teachers, friends, colleagues, and students. Today, we are very proud to present the CPC from the Department of Psychiatry. And as you know, psychiatry, like Dr. Puneet said, we would not have radiologies and we will not have pathologies, but we still have a clinical pathological presentation, and this one is going to be very interesting. Something about the Department of Psychiatry. Dr. Lalit Batra here is the superintendent with me. Psychiatric Center Jaipur is a premier institute of the state. This is for the treatment and rehabilitation of the mentally ill. Today, I have got some nostalgic feeling and something to tell you. This was exactly 40 years back from today, that is in the year 1984, when I joined this department. And probably I presented my first case in the department, and today I'm presenting my last CPC because I'm retiring after 2 months. It was established in 1952. The department has recently completed 70 years of its existence. It has got a annual OPD patient attendance of more than 2 lakhs, which includes new patients of about 170,000 per year. All at the psychiatric center, we have about 1,774 admissions in the emergency ward during 2023, and the indoor patients number was 128. Actually, the indoor number patients were double than this, but then we had a major change in our department because of the Honorable Supreme Court intervened, and we had to remove all chronic patients, which were actually ruining or like controlling half the seats of most of the mental hospitals. So they were shifted to rehabilitation centers. This is the bed strength of the psychiatric center, where the indoor patient is about 171 and emergency is about 42. We are proud to state that we have a ICU which is 4-bedded, and we take care of the post ECT confusions in the geriatric patients, which are taken care of in the ICU. The specialty services which are available at the department are de-addiction services, which are very, very old, since 1987. This was a Government of India initiative, and this was started in the main SMS building. Besides that, we have the behavior therapy and the biofeedback facilities available. We have child and adolescent psychiatry, geriatric psychiatry and memory clinic. And we are over a period of time, we are developing these clinics, and we intend to have a couple of more clinics like sleep lab and headache clinic and psychosexual disabilities. The facilities available in the department are biofeedback, modified ECT, RTMS, psychological testing, routine lab investigations, special investigations like EEG, ECG, X-ray, drug assay unit. I'm proud to stay here that though the government of Rajasthan started free medications very late, just a couple of years back, this department has been supplying free medicines ever since its inceptions. Most of the patients in this department have always been getting free medicines, and we have almost been. Right now, we are like bound by essential drug lists and other things. Otherwise, previously the purchase committee could buy any medicines, and we had the latest medicines in our hospital, which we still try to get them. And this department boasts of having medicines of every category. The faculty, when, like I just told you, 40 years back when I joined, we had one professor, one associate. We did not even have an associate professor. We had one professor and one assistant professor. Luckily, Dr. Shiv Gautam Saab, who's here, was the assistant professor when I joined, and he immediately got promoted within a few months. And today we have 4 units, and each unit has a professor. We have 6 professors, 2 associate professors, 3 assistant professors, 6 senior residents, and a total of 54 junior residents as of today. 40 years back, we were admitting 3 residents per year. Now we are admitting 19 residents per year, which is probably the highest in the country. Our department also runs a daily OPD at room number 29 in Dhanvantri OPD block at the SMS hospital, which has a different type of a liaison psychiatry patient group, which is usually neurotic in nature. And we usually get them as referrals, and we need referrals for these patients also. The academic activities have been very interesting. This was the only department in the whole state which was producing PGs till about 10 years back. As of today, almost all medical colleges have got postgraduate programs. The postgraduate courses started way back in 1979. So far, we have more than 140 graduates who have passed out from this institute. And we have like alumni in the US, in the UK, and Australia, and almost all over the world. And we have alumni almost in each and every department in the country, which I'm very proud to state. The department imparts training to postgraduates, undergraduates, psychology students, and nursing students, which involves theory classes as well as clinical work in outpatient department involves. And it gives us a matter of great pride that almost a lot of psychology departments from all over the world send their students here for training, and we give them a training from 3 weeks to like say 3 months. And the college benefits out of it. We get a payment seat, and we impart education to them. Regular teaching schedule includes case conferences, seminars, tutorials, review of literature, articles from journals, etc. And I'm again very pleased to announce that, like free medications, ours was the only institute which was running 5-day-a-week education academic programs since its inception. The center has been recognized as one of the regional centers for the implementation of National Mental Health Survey of India, conducted by NIMHANS Bangalore in the year 2015. Like the census, we have these national mental health surveys, and 2015 was a big year in our history because we were one of the elite colleges who got this chance out of the 7 colleges who did this. We were granted Center of Excellence in the year 2016 and 17, though it ran into rough waters, but we are still working on it, and we hope to start it very soon. The department is also recognized by Government of India for Regional Resource Training Center, RRTC in Geriatric Psychiatry. The Telemanas, which is the blue-eyed boy of the state and of the country today, is running very well. And this is a request to the administration here, and it has been discussed a lot of places that all OPD slips should have a telemanaska number, that is 14416. More than 500 doctors, multiple workers, community leaders have been trained in this department under the National Mental Health Program, which we are running regularly. Previously, the state nodal officer was from the department. Now it has been taken up by the Directorate Government of Rajasthan. But the teaching imparted to all the multipurpose workers, Anganwadi workers, doctors, and nurses is by the department. Our department has organized multiple conferences, has organized the Indian Global Psychiatry Initiative in 2010, World Psychiatric Association Conference and Regional Chapter in 86 and 98. We have done the IPS conference thrice in 87, 98 and 2010. We have organized the annual conference of Indian Psychiatric Society North Zone in 2003 and again in 2022. The second National Conference of Addiction Psychiatric Society of India, that is ADICON, was organized last year, and I'm proud to state that it was done in this premises itself of the college. Several state conference and workshops of Rajasthan chapter of IPS have been organized in the past successfully by the department. We have been doing outreach programs in the form of World Suicide Day and World Dementia Day, and we have been holding rallies, and we have had a Run for Health programs, and we have had Nukkad Nataks, and we have been doing a lot of innovative activities for which we are very proud, and I'm very thankful to the whole department in participating in this. This is an initiative to spread awareness and reduce stigma in the society. Our department has recorded over 250 publications in various national and international levels, index journals. Over the years, our department has won various prestigious awards like the Shantiniketan Award, IAGMH Award, the Bakshi Award, the A.K. Kala Award, and many more awards. But what is very impressive is that one of our PG students has just won the national quiz competition this year for our center. As far as the future vision is concerned, we foresee a bright future for this department as an upcoming center of excellence. And like Dr. Puneet Saxena said that the psychiatric problems have been increasing every day and the awareness has been increasing. The future of psychiatry becomes very bright and it is going to be very hectic. Under the guidance of our esteemed visionary principal and controller and our medical superintendent, we have made significant progress. The journey ahead promises to be equally exciting. With the planned expansion of the department, we aim to introduce super specialization programs such as DM courses and fellowship programs post-MD in field of child, adolescent psychiatry, de-addiction psychiatry, geriatric psychiatry, and consultation liaison psychiatry. Again, I'm very pleased to inform you that a couple of students from our center are the first ones to have done DM in addiction psychiatry and DM in geriatric psychiatry. We are in the process of establishing a state-of-the-art sleep lab facility at our department. Additionally, we intend to enhance our rehabilitation programs for patients with mental health issues. To further our mission, we will continue to conduct large-scale awareness initiatives to better acquaint the general public with mental health issues. Thank you very much.
Thank you, sir, for the exuberant presentation of the department. Now with this, I invite Dr. Abhijit Barza, third year resident from Psychiatry, to present the case for today's CPC.
Good morning, everyone. I shall be beginning with the case history. Patient DS, right-handed, 24-year-old male, educated up to BTech first year, currently not working, resident of Bhatinda, Punjab, was admitted at our department under the Section 86 of Mental Health Care Act 2017 that provides provision for voluntary admissions. The temporal framework of illness. Patient has an illness of 10 years total duration, insidious onset, continuous and progressive course, with a 2-year period of some improvement in functioning in between. Coming to the chief complaints, from 2014 to 2017, patient had the following complaints of pain, weakness and loss of sensation in left lower limb, followed by left upper limb, with diminution of vision in left eye, with loss of hearing in left ear. From 2017 to 2019, he had on and off physical pains on minimal exertion, although patient gained some functional improvement. From 2019 to till date, the patient has pain, weakness, and loss of sensation of bilateral lower limbs and followed by left upper limb, associated with diminution of vision in both eyes, associated with loss of hearing in both ears, associated with difficulty swallowing both solids and liquids, and difficulty speaking. The patient also has complaints of bloody vomitus since 18 months, and he has a lace-like brownish rash in the groin region that is exacerbated during the winter season. Starting with the history, the patient was doing well until June 2014, while in 10th grade. The youngest of 4 siblings, apart from attending school, would work part-time at an electronics repair shop. His sleep and appetite was within normal limits during that time. In July 2014, he started complaining of pain in great toe of his left foot, initially mild to moderate in intensity and not responding to regular painkillers. Within 3 to 4 days, the pain became intolerable, so much that he stopped attending school. On consulting a local doctor, cast was applied on the foot in view of possible soft tissue injuries. Over days, pain progressed to involve the whole foot, then the left leg. It was accompanied by inability perceiving touch sensations in that region. Over months, this progressed to proximal left lower limb, then to the trunk and the upper limb. By 2015, patient developed weakness of left lower limb. Initially, he had difficulty negotiating slippers, which later progressed to not being able to stand from sitting and walk without support. By 2016, he had started complaining of left upper limb weakness as well. Initially, he was unable to lift his arm over the head. Later, he could not hold or lift objects with his left hand. It was followed by complaints of decreased hearing in left ear, burning sensations on the left side of face, and blurring of vision in the left eye. During these years, he was hospitalized multiple times, underwent intensive workup, and had all relevant investigations done, revealing no significant abnormality. He was tried onto multiple treatment regimens, but to no avail. His condition remained similar until 2017, when he started showing some improvement with Ayurvedic treatment. During 2018 and 2019, patient sustained the improvements that he had achieved with Ayurvedic treatment. He had full recovery in vision and hearing, regained limb strength to walk with a limp, but had difficulty putting on shoes. He would frequently complain of pain that would be relieved after taking rest or painkillers. However, there were no hospitalizations during this period. In the month of December 2019, he once again complained of weakness of both lower limbs and was immediately hospitalized. This time, his condition worsened rapidly, such that over a course of 10 days, he was left bedbound. Over the next few months, he had also developed weakness of left upper limb. Weakness was accompanied by numbness and pain on trying to move his limbs passively by others. He started having difficulty lifting his neck, speaking, and developed diminution of vision in both eyes and hearing loss in both ears. He also started having difficulty swallowing both liquids and solids and would have regurgitation of food particles and water by mouth. Difficulty swallowing combined with decreased appetite led to a significant weight loss over time. His sleep duration reduced drastically during this time, and the family members would state that they would find him awake throughout the night. From the last 4 years, the patient is completely dependent on family members for his activities of daily living. Bathing, feeding, and dressing the patient is done by the mother. He moves about on a wheelchair that is pushed by attendants. Patient has a fishnet type brownish rash on the medial aspect of both thighs from last 3 years. The rash is noted to exacerbate during the winter months and somewhat settles during summers. During the years 22 and 23, he had complaints of vomiting blood almost daily, for which he underwent multiple consultations with the gastroenterologist. Coming to the negative history, there is no history of significant head trauma, ear or nose bleed. There is no history of urinary or fecal incontinence. There is no history of paroxysmal abnormal body movements associated with loss of consciousness. There is no history of prolonged fever, neck rigidity, or projectile vomiting. There is no history of symptoms suggestive of schizophrenia, mood disorders, obsessive compulsive disorder, or anxiety disorders. There is no history of substance use by the patient. Coming to the social functioning of the patient, dressing and self-care is accomplished with support of caregivers. Working at job or at home is completely impaired, and relationship with family members has also started to impair now. Coming to the treatment history of this patient, during the course of illness, patient has undergone multiple OPD-based consultations, inpatient hospitalizations, examinations, and investigative procedures. Common description of all these is well beyond what time could permit, thus we are mentioning only a few of those. Starting with the first one, the admission at Department of Neurology, PGI Chandigarh. After a detailed clinical workup and relevant investigations, a working diagnosis of CRPS1, that is complex regional pain syndrome, was made, and patient was discharged and continued on a treatment of amitriptyline, pregabalin, duloxetine, carbamazepine, but to no improvement. Psychiatric evaluation was advised, but the patient failed to follow up. Coming to the second admission, that was readmission at the Department of Neurology, PGI Chandigarh in 2021. This time, a differential diagnosis of conversion disorder versus infective inflammatory disease was kept. Key findings from the workup included normal VEP and BERA, no significant abnormality noted on MRI brain and MRI whole spine, inconsistent symptomatology with aggravation in presence of people around, a negative infective inflammatory and paraneoplastic panel, thus favoring a possible functional or a non-organic causation of patient symptom. The patient once again failed to follow with the department of with the psychiatry department despite being advised upon discharge. Coming to the family history and dynamics of this patient, the patient is the fourth-born child of a non-consanguineous marriage and currently lives with his mother and elder brother. Patient's father died around 20 years back. The cause of death, as per the family members, was some cardiovascular disease. On basis of account of symptoms provided by family members, retrospectively, a diagnosis of major depressive disorder is considered in the father. No history of substance use disorder or past suicidal attempts in the family members. Coming to the dynamics, relationship among family members had been cordial throughout all these years, but has started to strain now due to occasional abusive outbursts by the patient. Elder brother has been overburdened with the dual responsibility of earning a living for the family as well as taking care of the patient. Mother of the patient, who is also the primary caregiver, had once been a strong and independent lady. Now she breaks down several times a day, looking at her son's erratic behavior, constant complaining, and persistent insistence to consult new doctors and undergo procedures. Family lacks social support from relatives. The additional costs of traveling, admissions, investigations, and consultations for many years have caused a major financial setback. Coming to the past personal history, birth and development history was not suggestive of any abnormality. Behavioral and physical illness during childhood. There was history of school refusal starting from 4 to 5 years of age for unknown reasons. However, there was no history of bullying, initiated fights, inattention, overactivity, or poor scholastic performance. History of repeated lying without any apparent gain, and there was occasional complaints of low backache around age of 7 to 8 years. And the patient preferred to keep a pillow behind his back while sitting. However, this was not associated with any functional impairment. Continuing with the past personal history, education history, patient started schooling at 4 years of age. He was very good in academics. He completed class 10th state board despite illness, securing 96% marks. Completed diploma in electrical from home and joined BTech, which he left after first year due to illness. Coming to the occupation history, he worked as a helper at an electrical shop till 2014, and he opened an electric shop of its own between 2017 to 2019 when he gained some functional improvement. The sexual history could not be illicit, and marital history was not applicable. Coming to the personality traits of this patient, the social relationships with the family members is based on completion of needs, and he is apathetic to the needs of others. Regarding the intellectual activities and interests, the patient used to be fond of bodybuilding. He is very competitive about lifting, and he used to be very envious. He used to get envious when others could lift as much as he could lift. Coming to the mood, the patient mood becomes irritable, particularly when someone contradicts or fails to agree with him. Coming to the character and traits, the patient is a keen absorber and a keen observer and a very quick learner. He lies often and manipulates others. He has a habit of exaggerating events. He is generally energetic. About the fantasy life, he fantasizes about earning a lot of money and being in power. Coming to the habits, he has normal bowel habits and predominantly vegetarian by diet. The inference of the personality traits is that they are suggestive of cluster B personality. Coming to the general physical examination, the patient is lying in bed on a comfortable natural posture. The left arm is in hyperextension with inability to bend at the elbow, suggestive of possible muscle contractures. The skin has a fishnet pattern discoloration in groin region, and 2 marks of previous self-harm attempts are noted in the region of left forearm. There is no facial asymmetry, no pylorictus cyanosis, no foot deformity. Vitals are within normal limits, with the patient's height being 190 centimeters, weight 58, and a BMI of 16.1. That lies in the range of moderate thinness. Coming to the systems examination, most of the systems are within normal limits, and a detailed examination of neurological system would be discussed by the Department of Neurology. Coming to the mental status examination of the patient. As the patient has difficulty communicating due to deficits in vision, hearing, and variable compliance to instructions, thus conducting a regular mental status and higher mental function examination was not possible. Therefore, we employed the Kirby's method of examination and recorded the finding under following headings. Starting with the general reaction and posture, The patient had an asthenic build. He was clad in t-shirt and pajama, average kempt and grooming, occasionally moving right arm spontaneously, requires assistance in eating and getting dressed up. The behavior of the patient towards the examiner was apathetic. The voluntary posture of the patient was comfortable and natural, and when placed in an awkward posture, it returns to normal. The behavior of the patient fluctuates during the day with functional disability, responsiveness, compliance with instructions, and restriction in range of motion being exaggerated in the presence of examiner. Coming to the facial expression, the patient had a placid facial expression and shows distress and occasionally groans in pain on trying to passively move his limbs. Coming to the eyes and pupils, the patient's eyes were open with a normal blink rate. Gaze was evasive. The patient looks in the opposite direction after an initial eye contact with the examiner. Blinking in response to sudden movements of hand towards the patient was present. Pupillary reaction was present bilaterally, both direct and indirect. Corneal reflex was present, and the patient does not follow objects or sources of light when asked to do so. Coming to the reactions of the patient when he's asked to do something, the patient has delayed and inconsistent response to even simple commands. However, there is no negativism, automatic obedience, echolalia, or echopraxia. Coming to the muscular reactions, the tone is normal. There's painful restriction to passive movements of lower limbs. There's no drooling of saliva. The mouth is closed. No protrusion of lips or snout spasm is noted. There's no urinary or fecal incontinence, and there's occasional side-to-side movements of foot intermittently. Coming to the emotional responsiveness of the patient, no emotional responses are generated by the patient when the patient's own personal details are discussed with the family members. Patient shows startled response when the examiner enters the patient's room suddenly and on suddenly switching on the lights. There is no response elicited to jokes. However, family members often report him smiling in response to jokes when the examiner is not around. The patient has no spontaneous speech and talks to family members in examiner's absence, and the patient does not write when offered pen and paper. No abnormality was detected on lab investigations. Coming to the diagnostic formulation, a 24-year-old male educated up to first year BTech belonging to lower middle socioeconomic status from Bathinda, Punjab, living in a nuclear family of 3 members. He had a history of school refusal, frequent somatic complaints, persistent lying during childhood with cluster B personality traits, and family history of depression in father. He presented with a continuous and progressive illness of 10 years duration characterized by sensory motor disturbances of bilateral lower limbs and left upper limb, bilateral hearing and vision loss, with dysphagia, voice changes, fishnet discoloration in groin region, and hematemesis for the past 18 months. A mental status examination of the patient performed by Kirby's method revealed decreased spontaneous movements and speech, apathetic attitudes toward examiner, comfortable voluntary posture, fluctuating behavior during the day with exacerbation of disability in front of examiners, a placid facial expression, decreased emotional responsiveness, and sudden startle response to abrupt changes in the environment. Eyes open with the present light reflex and corneal reflex, evasive gaze, and an inconsistent response to simple commands. Higher mental function and insight grade could not be assessed due to patient's non-compliance. Based on the complaints with which the patient presented, a list of medical diagnoses was initially put together. First one was neurological or musculoskeletal system disorder. Second one was hearing impairment. Third one was visual impairment. And fourth one was any psychiatric disorder. For a detailed evaluation of the systems involved, relevant consultations with the concerned department were sought. Beginning with the consultations, first I would like to call upon Dr. Rahul Gupta sir, Associate Professor from Department of Neurology, SMS Medical College, to present his opinion on the case. Please.
Thank you, Dr. Vinit. So, continuing above discussion, so with the patient referred to our department with history of insidious onset, gradually progressive, predominant pain and weakness of all 4 limbs, sensory disturbances, bilateral vision disturbances, hearing disturbances, swallowing difficulty. And previously he was taken multiple of admissions, consultations, and what previously found was that patient has so much of symptomatology, but minimum signs, minimal abnormality on investigations. We again proceed with the examination of that patient. So higher mental function, patient was conscious but not cooperative. So detailed higher mental function we could not assess. His speech, the patient was apathetic, not responding to any question. But when we asked to relatives, he was able to speak in front of them without any examiner. Orientation to time, place, and person could not be assessed. He was right-handed. On cranial nerve examination, patient pupil's response was normal. Extraocular movement were normal. Muscles of mastications, corneal reflex was normal. Face was symmetrical, and gag reflex was normal. Other could not be assessed. On motor system examination, it was quite variable because the patient was poor cooperation. So we examined him twice on 2 consecutive days, and we found that sometimes patient was able to hold his limbs against gravity, and sometimes he was not moving any limb. So it was quite variable, and inconsistent response was found. However, the examination bulk generalized wasting, mild wasting was there. Tone was normal, though on passive movements there was some painful response was there. Power examination, because it was variable and fluctuating. Deep tendons were normal and present in all 4 limbs. Superficial reflex, plantar bilateral flexor, and abdominal reflex was normal. Sensory examination, cerebral examination, and gait we could not assess because of poor cooperation. So, considering some widespread disorder, to rule out some organic disorder, which could be some involving central nervous system as well as peripheral nervous system axis, we again investigated patient, and we found that MRI brain was completely normal, MRI spine was normal, EEG shows no significant abnormality, nerve conduction shows only mild motor affection that was not significant and not corroborating with patient's symptoms. EMG shows normal examination, normal insertional activity, spontaneous activity normal, MUPS and interference could not be assessed because it needs patient effort. So after detailed history, clinical examination of the patient, it was noted that the symptoms were inconsistent with signs and investigations and variable on different times of repeated examinations. And the patient was previously also investigated thoroughly at multiple centers, including ours, and most of which were normal and did not explain the nature and severity of patient's symptoms. So considering possibility of some neurological or non-organic disorder, considering conversion reaction or conversion disorder, we referred back it to Department of Psychiatry, and they taken the reference of Department of RRC. So I invite Dr. Om Prakash from RRC to further clarify. Thank you.
Multiple sclerosis.
Yes, sir.
Did you consider multiple sclerosis?
Yes, sir. Yes, sir.
As a differential diagnosis?
Yes, we consider it. That's why we advise CNS like MRI brain and spine, but it was completely normal. It is not possible that patient is having so much of symptoms of weakness of all 4 limbs.
The fluctuating level of waxing and waning of the symptoms.
Yes, sir.
The waxing and waning of symptoms over a period of time.
Yes, sir. Yes, sir.
In PGI also, if you go through the history, it was evaluated thoroughly.
Yes, sir.
And some symptoms have appeared every now and then, which pertain to higher mental functions as well as visual symptoms and the auditory symptoms which disappear, and over a period of time multiple symptoms at different points in time.
Yes, sir.
So MS is a possibility.
Yes, if we consider it, it is a possibility.
If you consider
Yes, sir. Yes, sir.
Yeah. So can we consider MS as probably
Multiple symptoms explain vision, hearing, motor system, but patient is also having so much amount of pain, which is if considered symptoms.
now this pain, is it an attention-seeking behavior?
Yes, sir.
That is another issue. Because attention-seeking behavior, if it is there, and it has been outlined by Dr. Abhi, that in the absence of the relatives, in the absence of the examiner, and in the presence of relatives, he is more comfortable.
Yes, sir. That shows.
That is a point which goes towards a psychiatric diagnosis, but from you as a neurologist.
We consider this as a differential diagnosis.
Okay.
Yes, I invite Dr. Om Prakash for further.
Can we take the discussions and the suggestions and please?
Any? Okay, right.
Good afternoon, all dignitaries, my teachers, colleagues, seniors, and students. So this patient was referred to Department of PMR from the Department of Psychiatry to rule out any musculoskeletal etiology for his current clinical complaints. We assess this case for muscle power, joint range of motion in all extremities, along with his functional assessment as far as possible to rule out any possible musculoskeletal etiology for his current complaints. The patient's chief musculoskeletal complaint was sudden onset of weakness since December 2019 in his bilateral upper limb and lower limb. Although findings were not consistent during repeated examination, but the most accurate findings are as following. We observed mild muscle wasting in all four limbs, and muscle tone was normal in all four limbs. The muscle power in the bilateral lower limb and left upper limb, the muscle power was 0/5, whereas in the right upper limb, the muscle power was around 3/5 at all joints. His hand function, we observed that he has poor hand function along with the poor grip, and again, the findings were inconsistent over the repeated examination. His breathing was normal. His respiratory rate was around 17, and he was not using any accessory respiratory muscles. So we considered that the respiratory muscle function seems normal. His active range of motion during examination, his active range of motion was full and free at right upper limb, whereas he was not moving his bilateral lower limb and left upper limb during my examination. His passive range of motion at bilateral lower limb and right upper limb was within normal limit, except he experienced mild pain during terminal 10-degree flexion movement at bilateral knee and hip flexion, and the range of motion at left upper limb was also normal, except at the left elbow joint, which was fixed in extension position. So during my examination, we did not observe any extremity contracture in any upper limb and bilateral lower limb extremities, except at left elbow joint, which was fixed in extension position. And during my sensory examination, the patient did not respond for any painful stimuli. He also did not respond for any temperature, touch, and 2-point discrimination, etc. But he screamed slowly during terminal 10-degree flexion movement at bilateral knee and hip joint during my examination. We did not observe any pressure ulcer or healed scar of any pressure ulcer anywhere over his body. His DTRs were normal in bilateral upper limb and lower limbs. His plantar was flexor bilaterally. He also did not respond for joint position change. Basically, it was not testable. During my examination, we did not observe any abnormal movements in upper limb and lower limb. As far as functional assessment is concerned, we assess based on the history that is given by his attendants and based on our examination. The patient was totally bedridden, and he is totally dependent on all bed mobilities, along with the transfer from the bed to wheelchair and from the wheelchair to bed as per history given by his attendants. The patient was totally wheelchair dependent, and he was even not holding his neck during assessment. He is totally dependent for all activities of his daily living in front of his attendant, or no one is observing him. For feeding and grooming, he is totally dependent on his attendants when they are available to assist them. But as per history given by his attendant, he finishes his food independently and completely without any assistant when no one observes him. Bladder sensation and control are present. His attendants are provides his urinal pot in bed on demand, and he voluntarily passes urine in the pot. The bowel sensation and control was present. His attendants shift him to the toilet seat, and he complete all toilet-related activities like wearing or unwearing his clothes and cleaning himself without any assistance. As far as the investigations are concerned, his X-rays of bilateral upper limb and lower limb were within normal limit. His MRI brain spine was normal, as discussed by Dr. Rahul Gupta, and EMG and NCN's findings were also normal. His blood investigations and other investigations like CPK, LDH were found within the normal limit. So, based on our history, examination finding, and investigation, we concluded that most probable etiology for his current clinical condition should be a non-organic or a functional cause, because since the patient is bedridden since 2019 and still there is no pressure ulcer or anywhere over the body, even though he is complaining of sensory loss, so this is not justifiable for any kind of organic etiology. He is again not having any kind of contraction in his bilateral lower limb, even though the power is 0/5. during my examination. So this is against the organic etiology. As the patient is bedridden since 2019 and still no significant muscle wasting was there, so this is also not justifiable for the organic causes. As far as the his functions are considered, he is totally dependent on his relatives for all activities of daily living. When someone is available to assist him, or no one, in some condition when no one is observing him, he finishes all his food independently and completely without any assistance. He also completes his toilet activities without any assistance when no one is observing him. So these functional activities are not in favor of organic etiologies. His DTRs are normal, plantar are flexor. These findings are against the human lesion. Normal EMG findings, normal NCS findings, normal CPK, LDH, and other blood investigation findings. These findings are against the element diseases. So we referred back this patient to the psychiatry department, concluding that he has no musculoskeletal etiology for his current clinical condition, and he should have a non-organic cause for his complaints. Now I would like to invite Dr. Dharamveer Singh to discuss on his ophthalmic conditions.
Good afternoon, everybody. This patient was sent to us for ophthalmological complaints. Ocular history. The patient was referred to our side by Department of Psychiatry with chief complaints of diminution of vision in both the eyes for last 4 years. Patient had complaints of diminution of vision in both eyes simultaneously since 2019, which was insidious in onset and gradually progressive and painless in nature. It was not associated with pain, redness, swelling, watering, photophobia, flushes, floaters, diplopia, etc. And past also, the patient had a history of an episode of diminution of vision in his left eye in 2014 to 17, which was insidious on onset and gradually progressive in nature, and was not associated with any diplopia, which resolved spontaneously, and the patient had no ocular complaint till 2019. All his complaints were with no history of ocular trauma, no ocular surgery, no prolonged ocular medications as well. On examination, facial symmetry the face was symmetrical on both sides. Position of eyeball was centered in both sides, and lids were normal. The blink lids were also normal. The lacrimal apparatus there was no regurgitation on both sides. Movements were full and free in all directions in both the eyes, but he was not following any commands. When he was given command to follow the objects, he was not doing that. Conjunctiva was normal, cornea was clear and bright on both sides. Iris was of normal color and patterns on both sides. Pupillary reactions was round, regular reacting on both sides. Lens was clear, and visual acuity he was totally non-cooperative. Pupillary reflexes, which are the main reflexes, suggesting visual intactness. Pupillary reactions and reflexes, both on direct as well as consensual, were present on both sides and were brisk. On fundus examination, the disc was absolutely normal on both sides, round with sharp margins, suggestive of no intracranial or some pressure symptoms. It was healthy with a neuroretinal rim on both sides, with cup disc ratio was within normal limits, and the foveal reflex was also normal on both sides. On optical coherence tomography, macular OCT showing no anatomical changes in any of the retinal layers. And on visual evoked potential study, this was to rule out any functional or cortical blindness. Patient underwent for VEP, which showed normal P wave latency on both sides. And our interpretation was that after detailed history and clinical examination of the patient, it was noted that symptoms were inconsistent with the ocular findings. Also, the patient was investigated thoroughly, most of which were normal and did not explain the nature and severity of the patient's symptoms. Considering the possibility of non-ocular disorders, we referred back the patient to our colleague, psychiatric department. I now invite Dr. Siddharth for giving his views about his ENT examinations.
Thank you.
Hello, good afternoon, everybody. Thank you, Dhamil boss. So this patient was presented to us with the hearing complaints. So when we evaluated this patient, we did took a detailed history and a thorough clinical examination. We found out, first of all, in the history, the patient gives a very unreliable history. He gives that between 14 to 17, he had some kind of hearing loss in the left ear, and now he presented with sometimes a right, sometimes a left, and sometimes a bilateral kind of a hearing loss, which itself gives a suspicion that this patient might not have an organic cause. So anyway, we proceeded with the routine clinical examination, the otolaryngology examination, and we did an otoscopic evaluation. That is the first step. And what we noted that overall bilateral tympanic membrane was very normal. There was no sign of any retraction, perforation, or anything that could suggest any kind of hearing loss, most probably a conductive kind of a hearing loss. Tuning fork test is the next step to evaluate hearing in such a patient, and it mostly depends upon the responses that is given by the patient. But this patient was very, very non-cooperative, although the tuning fork is a very simple test, which can be done not only by an ENT person, but by any, even MBBS doctor in his clinic. The nose and the oral cavity examination was absolutely normal. Now, this patient presented with 2 pure tone audiometry reports from 2 of the esteemed institutions in the country. If we look at the first report, I'll just, sorry, the cursor is not working. Okay. So if you look at this above graph, okay, so this above graph is for the right ear, and it is fairly normal except for the dip in the lower frequencies. If you look at the lower graph, both of the air conduction as well as the bone conduction are down, and there is a gap between them. So which indicates that this patient has not only a sensory neural but also has a conductive kind of a hearing loss, which is a mixed hearing loss according to that. Now we look at the other report, and here we see that in the left ear, both of the thresholds are fairly down. There is not much of a gap, which indicates that he has a severe, in fact, a profound sensory neural hearing loss. But here we also see in the right ear also is down. So the right ear also is a moderate. Now, this is if we go according to the report, but one of the biggest fallacies of pure tone audiometry is that it is a subjective test. We make the patient sit in a soundproof room, we make him wear headphones, and we give pure tones at different intensities and different frequencies, and he has to respond by raising a finger or some kind of a signal, and then the graph is recorded, right? So what is the best test to eliminate this fallacy? And that is the objective test, which is BARA. So a BARA, or a brainstem evoked response audiometry, was done. There are a lot of waves in the BARA, like the 1 to 7 waves. The most consistent and the reliable wave that we know is the 5th wave. And if all is fine with the 5th wave, all is fine with the hearing. This is what we generally assume. So if you see in this graph, in the 5th wave, basically, in all the different parameters, this was clearly normal. And what we see is that up to 30 decibels, which is also considered to be a normal threshold of hearing. So if you and anybody has got even a hearing loss, and even it's up to 25 decibels, that is considered to be normal. So this patient had a normal 5th wave up to the 30 decibels, which basically implies that the patient's bilateral hearing sensitivity was within normal limits. So, an organic cause of hearing loss, or in fact any kind of hearing loss, was most probably eliminated from our side, and we referred back to the Department of Psychiatry, considered maybe a factitious disorder or something, on which Dr. Gunjan ma'am would like to elaborate. Thank you very much.
So good afternoon, good afternoon, everybody. Now I will continue with the discussion. And what happened is that when we first saw the patient and we saw that there are multiple consultations and there is a 10-year history of continuous illness, we first seeked references from various departments particularly from neurological, because predominant presentation of patient was neurological, although there were other symptoms suggestive of organic disorders too. So we make all references, and what we found was the history was inconsistent with all the neurological, ENT, ortho, and PMR department findings. So after this we considered further evaluation, and these are the points which we found on evaluation. That is, references are done to departments, and then we considered a non-organic disorder which was hypothesized, and exploration of history was done, revealing the following findings. First was that despite being unable to move his with both lower limbs, left upper limb, and being unable to sit upright without support, he somehow continued to use the bathroom without assistance. Family actually has no clue how he did or manage all of those things. That is how he managed himself. At some occasions, consultation of the patients on dermatological consultation for the patients, somehow I missed it. At some occasions, patient's brother had actually seen the patient get up on his feet without any support and being able to move his hands, when the patient had thought no one was watching him. On confronting the patient with these observations, he became violent and even tried to self-harm on several occasions. Despite vomiting out half a mug of blood even day for 1.5 years continuously, his blood reports came out normal throughout, and upper GI endoscopy and USG whole abdomen were not suggestive of any pathology. At a later time, the patient mother even found her coloring liquid in his belongings. On dermatological consultation for the patient's skin rash, it was diagnosed to be caused by chronic heat exposure contact, that is erythema bignae, with the patient's brother confirming that he has often seen the patient put heating pad in the groin region, and the patient had denied using the heating pad altogether even after his brother's observation. Patient had a long history of reporting vague somatic symptoms. He urges family members to get him admitted to the hospital or to consult a new doctor. Even his behavior during hospital stay is peculiar. He underperforms and reports greater functional improvement in front of doctors and medical professionals more than what his performance is in front of his family members, even when watching. So his performance is best when it is not watched, worse when his family members are watching, and worst when a physician is watching or examining him. And family members have many occasions have found him using the mobile phone and talking to people, and on confrontation he denies using it. With these pointers to suggest a possible psychological or non-organic cause for the patient symptoms, we kept following differentials from our side using DSM-5. One is somatic symptom disorder, second is conversion disorder, that is functional neurological symptom disorder, factitious disorder, and a malingering disorder. About somatic symptom disorder, the points in favor was reporting multiple somatic symptoms that do not have a clear etiology and do not conform to typical clinical phenomenology. Also, the points against is there is no manifest distress in thought, feeling, or behavior, which is almost always present in somatic symptom disorder, because patient has significant concern with somatic symptoms the patient have, while this patient is relatively indifferent to whatever amount of pathology patient is having. So these points is against somatic symptom disorder. Secondly, there is concrete evidence of deceptive behavior and finding of some symptoms and perpetration of or simulation and exacerbation of illness, which is not found in somatic symptom disorder. It is never found in somatic symptom disorder. Second is conversion disorder, because predominant presentation of patient was with neurological symptoms, that is bilateral or say almost quadriparesis type of symptoms, and neurological symptoms are not consistent with neurological evaluation, and musculoskeletal symptoms disorder the presentation is also denied by any pathology from PMR department. So these points are in favor of, but point against is any concrete evidence of deceptive there is a concrete evidence of deceptive behavior perpetrated by patient to simulate and exacerbate illness. Secondly, most of the conversion symptom patients are exacerbated by presence of family members, and they are
not especially present in front of examiner. There may be conversion precipitations in front of examiner, but they are not exacerbated during examination only. And a patient with conversion disorder is relatively cooperative with the psychiatrist. It is not non-cooperative with the psychiatrist. While this patient is continuously defying to be seen by any psychiatrist or a psychologist. So all of these are against conversion disorder diagnosis. Third is malingering. In malingering, because patient has a concrete evidence of deceptive behavior, that is finding symptoms, exacerbating symptoms and presentations in present of examiner, and deliberately seeking medical consultations, that he even tried to harm himself for seeking medical consultations. All of these things are suggest malingering. But the thing is, point against is that behavior in malingering is motivated by concrete external factors, and there is a definite financial or some sort of material gain which is not present in this patient, and so malingering is being ruled out. Now, if we compare somatic symptom disorder, what is left with us is factitious disorder. So when we compare all of these three type of disorders, that is somatic symptom related disorder, factitious disorder and malingering, in somatic symptom disorder, the symptom production is not conscious, it is unconscious. Motivation is also unconscious. Patient is not motivated to produce symptoms, and there is no gain in form of external incentives or in reduction of primary conflict. And therefore we made a diagnosis of somatic symptom disorder. In factitious disorder, the production of symptoms is intentional, but the gain which occurs is unconscious. That is, it is internal or primary gain that we say, and motivation is totally unconscious. Although patient is intentionally producing symptoms, but there is an unconscious gain in form of mothering from medical system. Gain care. That is factitious disorder. And in case of malingering, there is total motivation is intentional, and there is secondary gain in form of either reduction in duties or a clear-cut concrete material gain. So there are certain clues in this patient which triggered the suspicion of factitious disorder. First, there is an atypical course of illness which doesn't follow the natural course of presumed disease, and a remarkable number of tests, consultations and treatments have been done to little or no avail. Then magnitude of symptoms consistently exceeds objective pathology, and symptoms are proved to be exaggerated by the patient. Some findings are discovered to have been self-induced, and laboratory tests dispute information provided by the patient. While seeking medical intervention, the patient actively opposes psychiatric assessment throughout last 10 years. While he was repeatedly asked to seek psychiatric evaluation, but he totally denied it. And further, I want to invite psychologists for presenting psychological evaluation, because we wanted to confirm the diagnosis, so we went for psychological evaluation.
Thank you for inviting. Good afternoon, all. So, in continuation of the discussion, after clarification of the history, he was referred for psychological evaluation. Firstly, I administered MMPI-2, that is Minnesota Multiphasic Personality Inventory. It is a psychological assessment tool for diagnosing and treating mental disorder for various psychological conditions, personality traits, and symptomatic patterns. My test findings are: MMPI provides scores on 4 scales: validity, clinical, supplementary, and content scales. Validity scale has 3 subscales: L scale, called as lie scale, moderate elevation on this scale indicating attempt to present oneself in a favorable manner; F scale, called as frequency scale, high elevation on this indicates exaggeration or fabrication of symptoms; and K scale, called as correction scale, low scores on this indicates lack of defensiveness and intentionally presenting himself or become a more symptomatic. And from the 9 clinical scales, in the 5 clinical scale, he get exaggeration, And in hypochondriasis, high elevation indicating preoccupation with health concerns, moderate elevation on depression indicating depressive symptoms, and high elevation on hysteria indicating somatic complaints and need for attention, and slight elevation indicating some suspiciousness on paranoia. And on schizophrenia, slight elevation indicating peculiar thoughts and behaviors. And on supplementary scales, obvious subscales are elevated on subtle scale, which leads to conclusion of possible exaggeration, and content scales also provides high on low self-esteem, health, and anxiety scales. So, summarized form, high F scale scores a fabrication of symptoms, elevation of hysteria and hypochondriasis scale indicates preoccupation with health and bodily symptoms along with the need for attention and validation, and low case scale score indicates difficulties or intentionality presenting themselves as more symptomatic. So for further clarification, I also apply facsimile assuming Convenor 22 scale for factious disorder, and in this also a score of 16 he got, and which indicates probable factitious disorder. So, and these all findings are integrated with comprehensive clinical evaluation including detailed patient history, direct observation, behavioral observation, and collateral information from other healthcare providers also and family members for a comprehensive assessment of factitious disorder. Thank you, and I again invite Dr. Gunjan for further elaboration.
Okay. So after further psychological evaluation, we finally came to a conclusion of a diagnosis of factitious disorder. I want to just introduce something about factitious disorder because it is relatively unknown disorder to all of the fraternity. Factitious disorder is also known as Munchausen syndrome, and it involves falsification of physical or psychological signs and symptoms with no obvious reward. The prevalence of factitious disorder is unknown, but in most of the literature it is considered to be nearly 1%. Mean 1% patients coming to any medical system comprise of factitious disorder, because these are those patients whose symptoms don't resolve even after standard procedures of treatment. They don't improve because because of exaggeration or finding or even falsification of the disorders. And factitious disorder usually have first onset in early adulthood, and individuals often have a history of multiple hospital admissions and are often willing to undergo invasive procedures. This patient also told that even you can give me ECT. He was ready for that, and he himself said that, I want ECD, you can also give me that. And so that's a type of, and patient may have a history of abuse or neglect as a child, experienced a true medical condition that lead to extensive treatment in childhood, or may have underlying malicious intent towards the medical profession. Definitely the child has some sort of neglect because his father died in 5 years of age, and after that he was one of the breadwinner of the family along with his brother. So that indicates some sort of neglect in the child. And personality disorder are common comorbidity in factitious disorder, and the overall prognosis is generally poor. When confronted, the majority of individuals will deny their behavior, and the reason for poor prognosis is mostly because they are discovered too late. Because whenever there will be a symptom of which suggests that there is no organic pathology, and even then patient is repeatedly presenting with symptoms, most of the time we also lose our patience. We see that whatever you do are finding, तुमको कुछ नहीं है, तुम जाओ, तुम बिना काम परेशान कर रहे हो, अपने घर वालों को भी परेशान कर रहे हो और ये भी कर रहे हो. All of these type of negative emotions or counter transference from the physicians to the patient lead to poor prognosis in these patients. If they can be found early, prognosis definitely can be improved. And it is also not a disorder which doesn't have a management. All psychiatric disorders have a management. Then these are the DSM-5 diagnostic criteria for factitious disorder imposed on self. First is falsification, that is deliberately finding of physical or psychological signs or symptoms, or induction of injury or disease associated with identified deception. Second is the individual present himself or herself to others as ill, impaired, or injured, and the deceptive behavior is evident even in the absence of obvious external rewards. The behavior is not better explained by any other mental disorders such as delusional disorder or any other psychotic disorder, which is ruled out already from the history, and specifier may be single or recurrent episodes. And this is the formulation of this particular case by this patient. Actually, this is the psychological formulation. Patient has a traumatic childhood, which is experienced from trauma doesn't mean that patient may have should have physical abuse. It is emotional, financial abuse, through which patient may have gone, which has led to feeling helpless and inability to control his situation because that was not in his control. This lead to attempt to master and feel in control, and due to which factitious disorder occur, because when they falsify, when they find illness, they feel in control of the situation because they then orchestrate everything around them, and that they orchestrate the medical drama according to which they see it as. Secondly, because of the early death of the father, the need of emotional solace he would have need, because he won't have understand at the 5 years of age. The grief is not expressed as such because the ability to understand grief and manage is not adequate for that age, which had lead to need of they don't want to confront loss at that time. They don't want to understand that they have lost someone so important in their life. This all leads to that this need of care, understanding is fulfilled by medical clinicians, family, and friends, due to which factitious disorder occur. Both of these mechanisms would have lead to factitious disorder in this patient. And through this behavior, his dependency and narcissistic needs are fulfilled. They provide him a role identity of a patient. Being a patient is also a role identity which have fulfilled, and the purpose in his life. And they actually then become orchestrators of medical drama which is occurring around them. So this is the probable formulation of this case. With all of this is the management plan. And so thank you everybody for listening me.
Thank you, ma'am, for such a wonderful case presentation. Now I invite Dr. Monica Jain, ma'am, to propose the vote of thanks.
Respected audience, the convener of CPC, Dr. Puneet Saxena sir, our esteemed guests, Dr. Shiv Gautam, always a pleasure to meet sir. Thank you for coming and gracing this occasion. Dr. I.D. Gupta sir, the PHOD Psychiatry department, who was very enthusiastic in the entire CPC, clicking photographs, putting it into the CPC group. So that was a wonderful thing from your side. Also, it will be a long-term memory for you, sir, as it will be as a head of the department, the last CPC for you. And I would extend my sincere congratulations to Dr. Gunjan Solanki and entire psychiatric department for producing such a lovely CPC, which was a great learning for us, and extremely beautiful presentation with the parallel departments like Department of Neurology, Department of PMR, Department of Eye, Department of Ear, that is ENT. So you can see that the amount of distress this patient has caused because the things were not addressed early. 10 years was the suffering time for entire family, and with a mark that there is no drug treatment. Whatever you can do is the symptomatic management, the counseling sessions for such kind of patient, and that makes this case a multidisciplinary case and a case to be discussed in CPC. With this platform, I always request, and I am doing it again, all the PPTs which the departments are preparing. Last time it was Deepak Maheshwari sitting here. Please send this CPC to MEU so that we can project the same on the website of our college, because this is the jewels, I would say. The jewel to our college is our CPC. Thank you all, and each and every one, the CPC team, for attending this wonderful CPC. And I'm thanking the students also who have now eventually taken time by a force that it has to be entered in the logbook. And please do put a summary report in your logbook. Thank you all very much. And the tasty samosa and tea is waiting outside. Thank you.